Today, we're diving into a genuinely fascinating intersection. We're looking at that exact point where the rigid, totally unforgiving mathematics of 3D geometry collides head-on with human, artistic intuition. We're talking about orthognathic surgery, and specifically, the surgery-first approach that was really pioneered and refined by the experts over at Changgung Memorial Hospital in Taipei. And listen, this isn't just about moving some bones around. We're talking about completely reshaping a human face. It's a process where absolute, pinpoint precision is literally the only option, and where science meets art in the most literal sense imaginable.
Professor Yu-Rui Chen actually framed the stakes for this perfectly. He said, the difference between beauty and the beast is in millimeters. And he's absolutely right. When we talk about these complex craniofacial procedures, we aren't dealing in broad strokes. A single, tiny millimeter can dictate the entire success of the surgery. It's literally the razor-thin line between a totally natural, perfectly symmetrical appearance and a noticeable deformity.
Okay, let's dive into this. Today, we're going to cover 5 key areas. First, navigating the 3D skull. Second, key cephalometric landmarks. Third, the single splint sequence. Fourth, avoiding nerve injury. And finally, the visual inference quotient.
Section 1. Navigating the 3D skull, the blueprint.
So, before a scalpel is even picked up, the surgeon absolutely must master the complex spatial orientation of the skull. Now, what's really interesting is if you think of the human head kind of like an aircraft moving in 3D space. To properly plan a jaw realignment, surgeons don't just look at a flat two-dimensional X-ray anymore. They have to calculate exact rotational movements along intersecting axes. It's basically a massive structural engineering problem, just wrapped inside human anatomy.
Let's define these terms real quick because they are the absolute foundation of the whole surgery. So yaw operates on the vertical axis, pitch on the transverse axis, and roll on the anterior-posterior axis. When a surgeon is correcting a facial asymmetry, they've got to translate and pivot the maxilla, that's the upper jaw, along these exact axes. And here's why this is so critical, right? Adjusting the pitch doesn't just change your profile. Surprisingly, it directly impacts the size of your airway. So rotating that upper jaw affects everything from the inclination of your front teeth to how well you breathe while you sleep. Crazy, right?
Moving on to Section 2. Key cephalometric landmarks. Mapping the canvas.
To measure that pitch, roll, and yaw accurately across a human face, we need fixed, unmoving coordinates. These are our cephalometric landmarks. First up is the nasion. This is the midpoint of the frontonasal suture, located right between the eyes at the bridge of the nose. Because of its strictly central, fixed location on the upper facial skeleton, it acts as the ultimate unmoving anchor point. Literally every other surgical movement is plotted relative to this one spot. It's basically the North Star of the face.
Now, deep inside the skull sits the sella. This point is located exactly at the center of the hypophyseal fossa, which is this tiny bony cradle that houses the pituitary gland. Because it's perfectly central and so deeply protected within the cranium, when you combine the sella with the nasion, it gives surgeons an absolute, unshakable baseline. This internal geometry is exactly what lets them confidently measure precisely how far forward or backward the jaws are actually positioned.
Moving down to the upper jaw itself, we have the anterior nasal spine, or ANS. That's the sharp forward-pointing bony projection. And then there's its counterpart at the back, the posterior nasal spine, or PNS. The relationship between the front and back of the upper jaw dictates how the entire midface projects outward. According to experts like Dr. Jeff Posnick, mapping these specific points forms the basis of the 8 critical quantitative decisions required in surgical planning. Simply put, you have to know exactly where the bone starts to have any idea where it needs to end up.
So what does this all mean? Well, what you really should take away from this is that these dry, kind of abstract anatomical points are the real secret to predicting a flawless, symmetrical outcome. Without establishing these fixed landmarks in 3D software first, planning a complex procedure, like a symmetrical cleft repair or a double jaw surgery, would just be sheer guesswork. These landmarks take a totally subjective face and turn it into hard, objective data.
Section 3. The single splint sequence. Theory to practice. Okay, so we've mapped the skull on our software, right? Now let's move to the actual operating room and see how this builds into a highly refined surgical flow. This is the Changgung Memorial Hospital's one-splint technique. It's incredibly elegant, but super technical. Step 1 involves BSSO cuts, meaning they carefully cut the lower jawbone lengthwise, but they don't fully detach it yet. Then, step 2, they move to the upper jaw for Lefort 1 cuts, entirely freeing the maxilla to be repositioned. Then in step 3, they go back down to finalize that lower jaw split. Step 4 is absolutely crucial. They wire the mouth shut using IMF, or intermaxillary fixation, with just a single final splint. And then finally, Step 5 locks the whole shebang down with titanium plates. Now, unlike the much older, traditional two-splint method that required all these intermediate steps and multiple surgical guides, this single-splint sequence is a real game-changer for the surgery-first model. Because all the cuts are made before anything is completely locked into place, the surgeon can actively mold the entire maxillomandibular complex in real time. It allows for on-the-fly, three-dimensional adjustments of both jaws at the exact same time. And that results in far superior aesthetic outcomes, especially when they're trying to correct a really severe facial asymmetry.
Section 4. Avoiding nerve injury, the crucial measurement.
As you can imagine, navigating these tiny spaces and shifting jawbones around carries immense physical risks. So the crucial point here is exactly 15 millimeters. When the surgeon is securing those newly moved jawbones with plates and screws, 15 millimeters is the absolute maximum safe distance for screw placement from the anterior. This exact metric ensures that the drill stays strictly within safe, bony territory. And the reason that precise 15-millimeter measurement exists is to protect the inferior alveolar nerve, or IAN. Repositioning the lower jaw means you have to split the bone right alongside this incredibly vital nerve pathway. Adhering to that strict safe distance is quite literally the line between a beautifully successful cosmetic result and a completely devastating long-term sensory nerve injury. A miscalculation here, well, it means a patient might wake up with a perfect profile, but they could permanently lose all feeling in their lower lip and chin. No margin for error.
Section 5. Visual Inference Quotient, the human element.
We've spent this whole time talking about rigid math, cephalometric landmarks, and exact 15-millimeter safe zones, but the climax of this entire surgery relies on pure intuition. It's called the Visual Inference Quotient, or VIQ. This concept was actually designed after analyzing top surgical masters, and this brilliantly illustrates how despite all the advanced 3D cephalometry and digital simulations we just went over, the final, perfect result relies entirely on what the surgeon can visually infer in their own mind. The VIQ is that final, unteachable millimeter of difference that comes exclusively from the human eye's judgment right there on the operating table.
Professor Chen gives some incredible advice about this deeply human element. He says, train your eyes to make the aesthetic judgment. If you are not satisfied, take it down and do it again till you get an aesthetically pleasing result. Get this, he actually advocates for taking a 20 to 30-minute break right in the middle of this intense surgery. Just stepping away entirely, maybe grabbing a coffee, just so your refreshed eyes will be sharper when you come back to evaluate the symmetry. I mean, think about how amazing that is. It just proves that human fatigue and subjective aesthetic judgment are still the ultimate variables in orthognathic surgery.
Which leaves us with a really fascinating paradox to consider. As we push further and further into this era of augmented imagination, where AI and 3D modeling perfectly calculate pitch, roll, and yaw down to the micromillimeter, can technology ever truly replace that human visual inference quotient? Can an algorithm ever actually replicate the artist's eye of a master surgeon assessing beauty? In real time, right there on the operating table. It's this delicate, incredible balance between the hard, uncompromising science of cephalometry and the profound art of human judgment. Something to really think about. Thanks for exploring this with me today on The Explainer.